just remember that these patients, these are human beings who had lung cancer. It's a scary disease, and we don't want to just sort of say, oh, well, that's a horrible disease. They probably won't do well. These patients are living longer. Our treatments are better. And so no matter who they are, they have every chance of surviving long-term for this.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello, and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking again with Beth Sandy, Thoracic Medical Oncology Nurse Practitioner at the Abramson Cancer Center at the University of Pennsylvania in Philadelphia, about survivorship considerations for patients with lung cancer. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome back. Thanks so much for joining us again today, Beth.
Yeah, Jaime, thanks for having me back.
So you've joined us for 2 previous episodes in this series about lung cancer, and we previously talked about screening and treatment. And so today we're going to move into the next phase, which is survivorship. It's interesting to talk about survivorship in the context of lung cancer because, relatively speaking, it's kind of not something that we've had the luxury of talking about when we think of survivorship defined as sort of post-treatment, long-term living with stable disease thanks to changes in treatments. We're seeing that more. So talk to me a little bit about how you have experienced seeing survivorship change in lung cancer treatment.
Yeah, I think just starting off, Jaime, when, we were looking at this podcast series on lung cancer and we decided that this was going to be a topic for the third one, I thought, okay, well, I'm going to, really search this because this is not something that really I've done a lot of speaking or publishing on in the past. And, if we sit and say, okay, what is survivorship in cancer care? Well, the NCI defines that as day 1 of your cancer diagnosis. So when I was thinking about what is survivorship in lung cancer, I was thinking we could really kind of put this into 3 different buckets. We could say, okay, bucket number 1 might be patients who have been treated with curative intent, are more than 5 years out from that curative intent therapy. So, are living long-term sort of post-curative intent therapy. The second bucket, I would say, would be patients who have advanced disease, lung cancer, but have responded very well to treatments and are living long-term, several years, with or without active lung cancer. And that bucket, too, has really been where we've had a lot of advances in lung cancer treatments, and we're seeing a lot more of these patients. And then I think bucket 3 would be patients who have advanced lung cancer and are on active therapy and, maybe are experiencing stable disease or progression of disease, and they are surviving every day with this disease, but their treatment is more palliative focused. We're doing more symptom management, et cetera. So I think for today's purposes, we'll probably talk about bucket 1 and bucket 2 of these patients who've been treated and are living really long-term with either their lung cancer in their rearview mirror or living with it, but yet not really active disease and maybe not even on active treatment at this time.
I think that sounds great. And I think those are really important distinctions to make because while the definition is inclusive, which is what we want for everyone to feel as though they are a cancer survivor, no matter where they are in their active treatment for that disease, as you mentioned, the needs, the focus of how we care for those patients really changes dramatically depending on kind of which bucket they might land into. So I think it's great to set up this conversation today with kind of defining those different groups and acknowledging that those groups are existing in all cancer diagnoses, not just lung cancer. And we're seeing those buckets kind of grow at different paces depending on the advances and the success that we're seeing with new treatments that are coming. So definitely a great setup to our discussion today. Let's start off with talking a little bit about some of the statistics. How many people are living with lung cancer in the United States today?
Well, so again, I was sort of looking into these statistics. So, you could take one statistic and say there are greater than 500,000 people living with lung cancer right now. And that would be either patients who are people who have had lung cancer in the past, don't have any active disease now, are greater than 5 years out and no active disease, but we still consider them, as we should, a survivor of lung cancer. And then there is currently about 175,000 people living year to year with active disease, whether that means that they're on or off of therapy, but they have, residual disease that we are somehow either monitoring or managing. We know with lung cancer, there's about 50,000 new cases per year, and that's a combination of men and women. And about 20% of them are over 5 years out from their diagnosis, again, whether or not they have active disease or not. So there's a big chunk of people who are living with either active disease or post-active disease.
And you mentioned earlier of just because we know that the survival rates, the long-term survival rates of patients with lung cancer is starting to really shift due to the success of some of these newer immunotherapies, targeted therapies, things like that. What have you seen in terms of the shift of these long-term survival rates?
If you look at all lung cancer and you say, what are the 5-year survival rates? Well, we would see those rates probably in the 20 to 25%. Now, that takes into account early stage disease. Now, if you break that down by stage, like if you have stage 1 lung cancer, your chances of beating it, quote unquote, or being alive 5 years or more, 5 years is kind of our cutoff in lung cancer. If you have gone 5 years and your cancer hasn't come back, we typically consider you cured from that. We still watch out for it, and we would still do annual scans, low-dose CAT scans annually. But that 5 years is kind of our mark. And so for patients with stage 1 disease, they have a pretty good chance of getting to that 5-year mark, somewhere probably in the 70 to 80% range, depending on if you're stage 1A or 1B. Then it starts to drop, obviously, if you go up stage patients. So for patients with stage 2 disease, these would be patients with either a larger tumor or possibly some adjacent lymph nodes that were positive at the time of surgery. For these patients, their chances of being alive at 5 years or more, this drops a little bit more. So now you're in the 50 to 60% range, again, depending if you're stage 2A, stage 2B. Once you get to stage 3, the chances of living to 5 years and beating it or living to 5 years or longer drops off. We're more in the 30% range, sometimes 40%. With some of our newer trials, adding immunotherapy, post-definitive therapy, adding targeted therapies for particularly EGFR is indicated there, EGFR inhibitors, these numbers look like they're rising and maybe even at some point soon could get closer to 50% of patients being alive at 5 years or longer. So that's exciting. Now, when we look at stage 4, and this was sort of that second bucket I talked about earlier on, when I first started doing lung cancer as a nurse practitioner, that was over 20 years ago, your chance of living to 5 years with a metastatic disease was 2%, 2, maybe 3%. It was very uncommon to live to 5 years with stage 4 disease. We didn't have much. We didn't have targeted therapies. We didn't have immunotherapy. We just had chemotherapy. We didn't even have a lot of chemotherapies back then, 20 plus years ago. But now I watch these American Cancer Society facts and figures, watch them each year. And this number has dramatically gone up. So we are now in that 6 to 8%. And I know that may sound small, but that's multiplied times 4 since I started doing this. I think this number is going to go up and up for patients living 5 years or longer with stage 4 disease. And we really attribute a lot of that to our advances in targeted therapies and immunotherapies.
You're so right. It's such a dramatic change over a relatively short period of time of just thinking back to, as you said, early in my career as well. It was just such a different landscape. And it's just been really interesting to be able to kind of practice alongside all these changes and see all these benefits to our patients. So hearing those numbers are pretty dramatic and really exciting. That makes this conversation even more important, knowing that we have that growing population of survivors of lung cancer. We really should understand now what their needs are and how that might be different. So what would you say? I know we're kind of going to ping pong between these two buckets of patients, but what are some of the main components of survivorship care? And are there any practices that you see maybe are unique to lung cancer survivors versus other cancers?
Yeah, so I think unique to lung cancer, and we'll talk a lot about this, but I think you're looking at sort of long-term effects of treatment you've received versus long-term effects of the disease in general. So for example, if you've had disease of the lungs, so lung cancer, if you look at your long-term issues, a lot of that is because of what may have occurred within the lungs. So for example, let's say you had radiation to your lungs or your chest. When we give patients definitive or curative intent radiation to the lungs, we don't only radiate just, let's say, a 4 or 5 centimeter mass in the right upper lobe. We also radiate the whole middle of the chest because the assumption there, and usually it's biopsy proven as well, is that the lymph nodes in the center of the chest also had cancer in them. And so unfortunately, when you're doing a radiation beam to the chest, there's a lot of vital organs there. It's not like, sometimes when we radiate the breast, we can kind of consolidate that. Now, there's still some radiation that gets to the chest. But when you're actually hitting the chest, and particularly the mediastinum, the center of the chest, you can't help it. The heart is in the way. The other lung, in addition to the diseased lung, is in the way. The spinal cord can be in the way. The esophagus is in the way. And so it's just really hard. Our radiation oncologists do a great job of trying to line those beams up. And the dosimetrists in radiation oncology do a great job trying to line those beams up to minimize toxicity to those other vital organs. But we just can't always do that. You may see long-term fibrotic changes within the lungs. You could see cardiac damage over time. You can see esophagitis or GI toxicity, particularly in the esophagus over time, post-radiation. And just the fact of having disease or cancer in the lungs, you can have breathing problems and pulmonary issues long-term. Another thing that kind of falls into that is if you had surgery, no matter who you are, you start with 5 lobes of your lung. You can't help that. You have 3 on the right and 2 on the left. The heart is in the way of what would be the 3rd on the left. If you take out 1 or 2 of those lobes, you're taking out sometimes 50% of your lung capacity. No matter how that is, later down the lines, you're just not going to have the reserve that others have. I have a patient, she's very young, and she had a bilobectomy, so 2 lobes taken out of her right lung early on. And she's survived many, many years now, over 15 years. And she used to be a runner and she still is. And she's like, I did a race with her one time, a 5K, and we finished together. And she says, you do have all 5 of your lobes, Beth. And I'm like, yeah, kind of right there. You're working.
Yeah, you're just tasting with her.
I know. I'm like, I really don't even feel good about this. But it's something you have to think about, like their reserve is not what that of is of another person, even if all their lung cancer is gone.
So when we think about receiving survivorship care, which we know can take on many forms and it's sort of operationalized differently, but what are some of the barriers that you see that might inhibit patients from being able to easily access the care they need? And how do you think nurses can help address them?
With survivorship care plans, it's something that we're starting to get into with lung cancer. We at Penn, we use Oncolink, which is a platform that was designed from our institution, though it's a national platform. And they have survivorship care plans that we've been instrumental in helping them develop. And so we like those. I think personally for a survivorship care plan, it's really helpful for patients to have dates, times, and what they receive. And, whether that's going to cause a long-term problem or not, it's just good to know that what you did and really what you didn't have. So, for example, I was thinking about this, in lung cancer, the chemotherapy agents that we use, they don't have as many long-term side effects as, say, what you may have had in breast cancer. So in breast cancer, they're using drugs like adriamycin and trastuzumab, which down the line after curative intent therapy can cause certainly cardiac dysfunction. We don't typically use drugs like that in lung cancer, especially in the curative intent setting. Some of our chemotherapy drugs can cause things like neuropathy, renal dysfunction, if they happen to have received a etoposide that has a very small but possible long-term effect of developing leukemia later on. But typically, most of our drugs don't have a lot of long-term effects like we've seen in other cancers. But it's good to know on your care plan, what did you have? When did you have it? And that can help primary care or survivorship providers down the line to say, okay, you didn't have an anthracycline. You didn't have a targeted therapy that may have caused this or that. If you do have neuropathy, we say, oh, you did have a taxane. Have you had this neuropathy since the taxane? Or is it something that only came on 10 years later? So it's probably not related to the taxane. And we should figure out why you're having neuropathy. So I think it's really helpful to have the care plan to have an understanding of what you did and what you didn't have and when you had it and how long ago was it and what those doses were. Were they really high doses of the taxane or were they low dose weekly that likely didn't have that much of effect? And I think that's particularly in our care plans, what we focus on, what you had, how much of it did you have and when did you have it? And that can then be implemented, years down the road to kind of look back and say, okay, what did you have? And that goes for surgery and radiation as well. What surgery did you have? When did you have it? When did you have radiation? Did you have it palliatively at lower doses or did you have like a full definitive dose of it?
Well, I think you bring up a good point of that. Again, there are different models. Some clinics, some cancer hospitals or sites have their actual own unique dedicated survivorship program and staffed by dedicated providers versus just going back to maybe your regular medical or surgical oncologist. So there's different ways to do this. But I think what you have highlighted so well is that a lot of the issues that we find in survivorship aren't necessarily things that we as the oncology team actually can fix. We can't always necessarily treat them. We are the best, I think, to identify them and to monitor for them. But when they do present themselves, or even if we're trying to proactively avoid them, we have to engage with those subspecialists in those areas. Cardio-oncology is certainly a growing specialty for many of our cancer survivors. And so, as you mentioned, that care plan can be that source of truth. So year over year, and we know that people move or providers move and leave. And so there's always maybe a shifting of the care team. And so having that single source of truth that helps kind of keep us grounded. And as you said, what'd you get? How much did you get? When did you get it? Because that really is what gives us the information we need to proactively watch for those things and make those connections to the right specialist to help care for those patients. So when we think of all of those competing needs of different specialists potentially helping to support survivorship care, access to care and disparities, I think, can really influence a patient's ability to access the care that they need. So have you seen any examples, or do you know of any examples of how disparities, and whether they're kind of social disparities or determinants of health, that really can impact an individual's ability to access the survivorship care that they need?
I mean, you just said one of them, having a cardio-oncologist. I'm lucky at an academic institution where we do have a cardio-oncology department who is really in tune to managing those specific needs. But, you may be in a rural location or somewhere where you may only have one oncologist, certainly let alone not having a cardio-oncologist or a dermato-oncologist, somebody who's very specific to managing dermatologic needs in patients who've had oncology treatments that may have interfered with a lot of dermatology stuff. So I think that's one thing that has been difficult. I think another thing too that I would say is, unfortunately, part of survivorship in lung cancer is smoking and smoking cessation. I know it can be hard for people to quit, even people who've had curative intent treatment for their lung cancer. And so keeping up with smoking cessation, and that can be hard, again, if you don't have access to maybe a smoking cessation specialty, or if you live with other people who smoke and don't have really access to programs to help you quit and help you just have stay quitting. And so that's a really important part of survivorship in lung cancer, is continuing to abstain from smoking. So those kind of, smaller subset or subspecialties are something that I think can really impair good survivorship care if they're not available.
And then certainly any challenges or disparities that influence just access to the initial treatment will likely carry over into accessing survivorship care. So whether it's transportation, being able to get time off work, those types of things where those usually don't magically fix themselves during the midst of active treatment. So again, anything that we're doing to assess patients for any barriers to their care up front, those assessments typically led by nurse navigators or coordinators, really have to continue even through a survivorship care, because those needs may be exactly the same. They may change over time, but just knowing that those challenges will continue to present themselves. And so whatever we can do to help identify those barriers, mitigate them as best as possible to make sure patients can stay adherent to their follow-up schedule and needs, really important.
Yeah, actually, it's funny you say that. You're like jogging my memory of patients of mine who, had surgery, had adjuvant chemotherapy. It was really hard for them to get off work just to do that. And now they're in their surveillance CAT scans, which may be every 6 months, it may be once a year. And I've really had a hard time with some of them even wanting to take the time off to get the surveillance scan. They feel like, well, do I really have to take off work to do this? And the telemedicine era since COVID has actually been really helpful for this, because if they can get their scan on a weekend and then it's hard for them to take off work during the week, I can usually carve out a time where I can do a telemedicine visit with them to review their scan and see how they're doing, particularly if they're on an every 3 month or every 6 month scan schedule. I do try to see them, at least lay eyes on them once a year.
But you're right. It's a great convenience that for many institutions are continuing to form and allow for these video visits, the telehealth visits, and certainly a very appropriate use of them for patients who are doing well, feeling good, just primarily getting some follow-up scans and things, certainly a benefit and a convenience to them as well. So I'd love to hear that you're able to do that. Speaking of surveillance, what are some of the typical either procedures or ongoing tests that are performed for patients who are in these survivorship phases? And how often should these types of tests be performed?
Yeah, so it depends on your stage. So for early stage, like stage 1, we generally only do annual scans, like once a year. If they were like a high risk 1B, maybe every 6 months. When you get to stage 2, we do every 6-month scans. And again, these are CAT scans of the chest. We'll do with contrast for the first year, because that's really the first year. You could argue the first 2 years is the time when lung cancer is most likely to come back. So sometimes we'll be more likely to get contrast during those times, just to make sure like the liver's lighting up. We can see the lymph nodes in the chest very well. After that, and with stage 2 disease, after you go 2 years at your every 6-month interval, we can then go to annually for those stage 2 patients. And we would drop the contrast at that point and just do non-contrast CTs of the chest. Now for stage 3, we're going to do every 3 months. Every 3 months for at least the first 2 years it is. And then we can go to every 6 months. Now that can change at any time. If you get a CAT scan and they say, there's something questionable, we're not really sure. I love it when radiologists say in their assessment and plan or in their impression, the radiologist says, I would recommend to repeat a CAT scan in 3 months to follow up on this finding, because then that gives me ammunition when I call the insurance company, if they're trying to deny it and say, you only need to do it every 6 months, that will say, well, radiologists themselves said we should do it in 3 months because there's a concerning finding. So you have to really look at those reports. But in general, for stage 3, it's going to be every 3 months for a couple of years and then every 6 months. The earlier stages, it can be annually or every 6 months, depending on exactly the stage. When you're in stage 4, I will tell you, some of these patients with targeted therapies and immunotherapies, even in stage 4, after 2 or 3, 4 years, they might go off treatment. We still will scan them every 3 months for pretty long. Now, I'm thinking of a patient of mine that I saw this week in clinic. He was stage 4. He had brain metastases. He had adrenal metastases. He was on immunotherapy for 2 years, had a complete response. He's now been off of all treatment for over 2 years, which is awesome. He continues to have no evidence of disease.
That's amazing. I
know, it's awesome. So we now have switched him to every 6-month scans because, at this point, bringing him in every 3 months was just, he's had no evidence of disease for 2 years. So that would be sort of one of those less likely cases, but one that we would say, okay, we feel pretty good about every 6 months for you. So it really depends. It's a CAT scan. It's not a chest x-ray. It is a CAT scan. And then once they get to 5 years, so let's say you've had a patient with stage 2 resected lung cancer, and they're now at 5 years, that's sort of the magic number where we go to once a year scans, sort of no matter who you are. If you're off treatment for 5 years, nothing's showing up, we'll go to once a year. And I even tell the patients at that point, they can go back to their primary care doctor if they want. Now, we still would do it not as a low dose, not a screening, because it's never really screening anymore once you've actually had lung cancer. So it's still a surveillance scam, but just once a year.
Well, and again, you just a great point of how that transition in survivorship can and should involve primary care physicians or other specialists that the patient might be seeing, of just involving them and allowing them to participate in part of that long-term surveillance. So when you do get to that 5-year mark, and if the patient, they want one less doctor to come see, that sometimes it's the right time and it's appropriate to, share that responsibility with the primary care provider. So great examples of just how talking with the patient, really having that shared decision-making conversation about really what is best for that patient, that unique patient and their circumstances, really helps to customize the treatment and help them feel that they do have control on how their care is conducted. So those are some great examples. We already talked a lot, I think, about some of the long-term and the late effects of the treatments that can come with receiving lung cancer treatment. But just at a high level, again, to review, what are some of those predominant long-term effects and late effects that we see for the most common lung cancer treatments? Which treatments are they associated with?
So we already talked about radiation and surgery, and I touched on chemotherapies. Like I said, the chemotherapies that we use in lung cancer typically don't have a whole lot of long-term side effects. Like I said, neuropathy can be one that can be nagging on and on. And, cardiomyopathy is another one. If some of the targeted therapies, particularly the EGFR inhibitors that we use, can cause cardiomyopathy. So if they've had that as a result, that can sort of stick with them. The other thing I didn't mention that I should talk about is autoimmune diseases as part of immunotherapy. So we give immunotherapy now in the curative setting, preoperatively, postoperatively, post-chemoradiation. So they may get a year or so of immunotherapy. They may develop some sort of autoimmune toxicity from that. Usually that will go away once we stop the immunotherapy. But I've seen some things persist over time. Now that can go anywhere from like mild eczema that kind of came about to things like more serious, like maybe lupus or scleroderma that may have developed as part of your immunotherapy. And we may stop the immunotherapy, but that may linger on. So those are things that we have to keep into consideration if they developed a pretty significant toxicity from immunotherapy.
That's a great point of just the uniqueness of immunotherapy and not only the difference of side effects that we see during active treatment, but just the unique ability for them to sometimes appear later or linger far beyond what we would normally expect with some more conventional chemotherapies and treatments. And so that is knowing that so many patients with lung cancer are receiving immunotherapy as part of somewhere in their treatment plan. Certainly something that we as nurses have to always keep in mind when we're talking with patients and helping to monitor for any of those late or long-term effects. What are some of the most important education points that you think we should be sharing with patients and their caregivers about what to watch for, whether it's related to side effects from their treatment or for signs or evidence of recurrence?
Well, I think this can be really hard. And I mean, we didn't get to the psychosocial aspect of this yet, but I think this is a good point to go into that, is that anything medically that is wrong with them, they should reach out to a provider. Now, if it's your primary care provider, if it's common cold, that's fine. But I think if the primary care provider is not sure, I think it could be time to reach out to the medical oncology provider, just because we might be a little more in tune to what we've given you and what might be going on. And I think this starts to lead into the psychosocial aspect of survivorship in lung cancer care is really difficult. You're living with a disease that is likely to come back. And even if it hasn't for years, particularly if you had stage 4 at the onset, you're constantly worried that every little thing that you feel might be recurrent disease and might be a death sentence. And it's really scary for patients of ours. And so I always say, like, no matter what it is, just let us know and we'll help you tease out whether it is something from your treatment, whether it could be a sign of recurrence. And we will know what the right test is to order to rule that out and hopefully put their fears at ease, depending on what the symptom is. But I think the psychosocial aspect of lung cancer survivorship is really, really hard. It's just a worry, a constant worry that, this could come back. And is every time I get a cold, is it lung cancer? Every time I get a little out of breath, is it lung cancer?
And you're absolutely right. I think, I remember always saying, I would rather you call me. And I can tell you that it's absolutely not related at all to your cancer that we treated you for versus you not call me and just worry about it on your own. Or if it is related, then the sooner you call us, the sooner that we can investigate it and make a plan from there. And so while yes, we will always have patients and their families who are more inclined to worry, and that's just part of it, but giving them that reassurance that, we want to hear from you. We want to know if you have concerns. We want to help discover what they are and help find a treatment for them or just be able to give them that peace of mind. I really like that advice. And you're right. The psychosocial is unique, I think, for lung cancer. And, the diagnosis itself brings a uniqueness of stigma that we know is associated with it. And so not only do they likely carry some of that through their active treatment, but on the other side of that into a survivorship phase, I'm sure those feelings and issues are still manifesting and they're still working through those as well. So it is just a very complex disease to live with that just complicates the survivorship phase even more. Now, you touched briefly on this as well, but let's just review. What are some of the key lifestyle modifications, prevention strategies that we as oncology nurses should share and encourage our lung cancer survivors to conduct to promote for their long-term health? And some of that is not only for them, but also for their family that they live with as well.
I think a lot of it's common sense. So don't smoke. And hopefully the people in your household are not going to smoke either. So just promoting smoking cessation for both the patient and those around the patient is number one. Certainly nutrition and exercise, and that's general health. So I don't think that that's necessarily any different between any other type of cancer. But it's a good reminder to say like, hey, your body basically underwent assault from our treatments, whether it was surgical, radiation, chemotherapy, immunotherapy, whatever it was, your body took a hit from this. And so keeping up good nutrition and exercise will help you feel better, as you live long term. And then I think the other thing too is just reminding patients who've had lung cancer to do their follow-ups. Sometimes and some of our patients with lung cancer haven't necessarily led the most healthy lifestyle up until this point. Many of them have smoked. Not everyone, obviously, like 20% of our patients have never smoked. For those patients maybe who didn't have as healthy of a lifestyle, maybe alcohol, smoking, whatever it would be, is to say like, hey, like we want to keep up on all aspects of your health, not just your lung cancer follow-up, but also making sure you're following up for your annual well visit with your primary care doctor. You're getting your other cancer screenings done outside of lung cancer. Just the reminder to keep up your general health. And that, again, may not be as strongly received in a patient who maybe has not had the healthiest lifestyle up until that point.
You're right. And certainly not unique to lung cancer, but sometimes when we first meet our patient, they come to our care, it's maybe the first time they've seen a doctor ever or in many, many years. And so sometimes it's the Pandora's box of uncovering several chronic conditions that maybe weren't diagnosed or hadn't been managed. And so you're absolutely right. Helping to get them through all of this. And if they get to that other side of being more in surveillance or long-term kind of maintenance type treatment, it's not the time to sort of give it all up. They worked so hard and they fought through. And like you said, they survived what we put them through. And so, now's not the time to let those other things just go by the wayside. So encouraging them to stay focused and continue to see those routine visits for any health conditions that we may have found or caused perhaps during their treatment is just really important. And I also really like emphasizing for my patients, especially that, yes, you had this cancer and we've treated you for this cancer, but we haven't eradicated the risk for any other cancer based on this treatment. And so keeping up on all of those screenings as guidelines recommend is really important. So that's a great point to emphasize as well. Well, Beth, thank you again for joining us today on this final edition of this lung cancer series. It's been great to talk with you along these 3 episodes and really get a nice sort of comprehensive picture of lung cancer. And so I really appreciate your time and your expertise. As we get to the end of our episode today, we like to always run through that final series of quick questions just to help summarize the things that we've talked about today. So to start that off, how do you think healthcare professionals should evaluate their own personal hidden or implicit bias about lung cancer survivorship?
Just remember that these patients, these are human beings who had lung cancer. It's a scary disease, and we don't want to just sort of say, oh, well, that's a horrible disease. They probably won't do well. These patients are living longer. Our treatments are better. And so no matter who they are, they have every chance of surviving long-term for this.
What are some common misconceptions about lung cancer survivorship?
I would say the most common one is that maybe they won't survive long-term. So like a small nitpicky thing of mine is that I once had a patient who was doing very, very well with stage 4 lung cancer on immunotherapy, but had the worst hip. And this guy needed a hip replacement so bad. People get to the point where they can't even walk on their poor hip. And the guy was like, I'm not doing a hip replacement. He has stage 4 lung cancer. Well, Jaime, I got so mad. I said, how would you feel if you are beating your lung cancer, even though stage 4, you're living long-term on immunotherapy, you're living a great life, but you can't walk because your hip. I said, find another orthopedic doctor. I'm like, where you're getting your hip replaced. And he got his hip replaced and he felt so much better. I hate it when they just write people off with lung cancer.
That's both a horrible story, but also very validating to know that you helped advocate for that patient and helped educate some of our colleagues about the realities of living long-term with lung cancer. What's something about this topic that's not often discussed, but you wish people knew more about?
I think that in lung cancer, you can live longer nowadays. Like I said, we've multiplied times 4 the 5-year survival rate for stage 4 patients. And I think that's going to go up and up. So we need to start thinking about the fact that these patients are going to live longer and make sure that we're facilitating a healthy lifestyle along the way so that those lifestyle modifications can then last long term.
And then finally, what recommendations do you have to help oncology nurses stay current on this topic? Or are there resources that we can share with our patients or other providers that we work with just to help everyone sort of learn more?
I think just remembering that these care plans do exist and they're not cumbersome. just find whatever your care plan source is. I mean, I shared mine, but whatever you want to use. And, at the end of treatment, patient has a summary to say, like, this is what I got. This is how much I got. This is when I got it. And then they can keep that with them and they can have that so that as their care goes on, like you said, maybe they move to Hawaii, maybe they move to Alaska. They have that information with them to share with their providers.
Well, Beth, thank you so much. Thanks again for joining us on our podcast today. Do you have any final comments to share with our listeners?
No, I think we covered pretty much. I'm just excited that we can talk about survivorship and lung cancer now.
Absolutely. Well, thank you again. Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.